Good evening.
So thank you all for inviting me to be a part of your class. Um, a little bit about me, and I do have a slide deck that I want to share. Did everybody get the email that I just sent with a case study in it?
Yeah, I received it.
Yes.
Uh,
Yeah, I did.
okay, perfect. So my name is Dr. Jessica Love Jordan. I'm an assistant professor at Governor State University in the Addiction Studies and Behavioral Health Department. And I teach undergraduate addictions courses. So some of you may have taken a class with me if you did your undergrad with Governor State. But I also teach in the Master's in Addiction Studies program. I'm also like a three-time Governor State alum, and I graduated from the Addiction Studies Master's program and the PhD program at Governor State. So that's a little bit about me. While I get my slide deck up, I'm interested in hearing from you all. What kind of experiences, if any, have you had working with addictions? Now, is this a fieldwork class?
Yeah, so this is practicum two for the master's level counseling program. So they've all been seeing clients for about a semester and a half
Okay, fantastic. Does anybody have any experience working with people who are coping with substance use or other addictive disorders?
I do.
Okay.
Um, okay, I'm trying to put my camera on. So, hello, my name is Tanine Brinson, and a couple of years, well, more than a few years ago, I worked at it was called Renewal House. I lived in Nashville. It was one of my first jobs. I started doing case management and stuff like that, but then I started working for the methadone clinic, and so that was a real interesting experience. But that was that was my first interaction with supporting, providing resources, monitoring individuals who were in active addiction.
Okay. Now, when you say interesting, what made it an interesting experience?
You know what? I don't know if interesting was like the best word, but it wasn't something I was necessarily familiar with. I've had family members and things like that, but I think when you truly work up close and personal, you really get to see the struggles, the barriers, and I think sometimes from an outside perspective, people really don't understand. This is not just somebody who got up one day sometime and just started to do drugs or whatever. They all had a story to their journey, and so that it changed my whole perspective on what that entails.
Absolutely. Absolutely. Any other experiences? So Tanine said something really important that I want to highlight. People have stories. And I think, unfortunately, our society, especially media portrayal, does not do a good job of highlighting that people actually have stories. So I've been practicing for a little over 7 years now, and I've worked in a few different settings. I've worked in hospitals, outpatient facilities, inpatient facilities, and out of all the hundreds of clients I've interacted with, I have not met a single person who said, you know what, I just woke up one day and decided that I wanted to destroy my life with alcohol. Because it typically does not happen like that. I've found, and this is just the feeling, um, a lot of the time when somebody develops a substance use problem, it happens very covertly and progressively. So the people around them may see things changing, but the individual, because the changes can be so subtle, a lot of it happens outside of their awareness. And we'll kind of talk about the mechanics of it. Can everybody see my screen? It should be a title slide that says Understanding Co-occurring Disorders.
now. Yes.
Yes, I can.
Perfect. Okay. So I like to be interactive. I'm going to talk to you and hopefully you'll talk back to me. If you have any questions, the only thing I ask, because you all are little boxes, if you use the raise your hand function, it's going to bring you to the top of my screen so I'll be able to get to it. But please, if you have any questions or comments that you feel like would enhance the learning experience, don't hesitate to join in. So I'm not just a talking head for the next 45 minutes. So I mentioned I'm Jessica Love Jordan. I work in the Addiction Studies Department, developing substance use counselors. And for our time together today, I want to talk about the prevalence of co-occurring disorders, some of the key concepts of providing integrated care, which I hope you all will be interested in doing, and some of the evidence-based strategies that are associated with working with people who have substance use and other addictive disorders. The good news, all of the skills that you're learning and practicing now are transferable. So it just takes a little more information to be able to apply that effectively with people who are coping with substance use and other addictive disorders. So with that said, when you hear the word addiction, what comes to mind?
Drugs.
Okay. Anything else? Does an image come to mind?
I typically think of alcohol first,
Hmm.
and then drugs, usually.
Okay.
Yeah, to me, I think of drugs first, like yeah, drugs and then alcohol, but also pleasure, like something you cannot leave in thought.
Okay. Any other thoughts?
I
I
think of
think about
gambling.
withdrawal symptoms.
Hmm. Withdrawal.
Withdrawal.
Anything else? So we had one person that said they had experience in working with people with substance use concerns. Oh, Dejanay said homelessness. Yeah, sometimes. Uh, do you all have any concerns about working with the population or questions? Like, if you could rate it on a scale of 1 to 10, with 1 being not at all and 10 being very much, how comfortable would you say you currently feel? How prepared would you say you currently feel?
Right. Janine and Denise said 8. They
Gabrielle,
said 7.
so we feel pretty comfortable. No, that's great. Gabrielle, you had a question?
Yeah, so I just want to share something really quick. So I did had an experience working in a substance use clinic.
Mm.
I was not able to do clinical work because of the level of my education. I was just with a bachelor's degree in psychology. Um, it was a great experience, and answer your question, I think my comfortability working with this population is about 6. The reason I say that is because most of the clinicians I saw over there, either they went through substance use addiction, so now they find a lot of meaning working with these clients, or they have a family member who is struggling with addiction, and they see a lot of meaning doing that as well. So they can relate to the clients pretty easy.
Mhm.
For me, it wasn't that easy to relate to them because I've never had any experience with that concern. So that's the reason I give a 6, like the level of comfortability. I don't know if I answered your question, Dr.
Oh,
Jessica.
it did. It did. It answered it really well, actually. And that is not an uncommon concern. Like, just speaking from my own experience, I do not have a personal history in recovery outside of like quitting smoking. So, coming up as a clinician, that was something that I worried about. Like, how are people going to receive me if I'm not in recovery? But I came to understand people are really just looking to see, can you not necessarily relate to my exact lived experience, but can you hold what I have to give? Like, hold what I have to share in a way that's non-judgmental, that's not shaming. Um, you occasionally get people that'll ask if you're in recovery. You find different ways of answering. Like, I'll usually answer with another question. Is it something that's important to you? What makes that important to you? Like, what is it that you truly want to know in asking
Mm-hmm.
that? Because it's usually more like, can I be transparent? Can I be honest about my experience with you? And you
Mm-hmm.
be able to receive that in a way that's non-judgmental.
Mm-hmm. Makes
But
sense.
that's a common concern. But you don't necessarily have to have lived experience. I'm going to go on a limb and assume that everybody here has tried to change something. to
Yeah.
varying degrees of success. Okay. Have you ever tried to change something and you weren't successful?
Definitely.
Okay.
Definitely. Um, just I guess not procrastinating. That's one of my difficult changes to make.
You and me both. Okay. So, assuming that everybody has had the experience of trying to change behavior, and a good portion of us, if not all of us, have had the experience of trying and not being successful. If that is true, then you understand what it's like for people, to an extent, with substance use disorders who are seeking treatment. Because it's all centered around behavioral change, and behavioral change is inherently hard. We're creatures of habit. We like patterns. We build
Mhm.
lifestyles around certain ways of being, certain coping skills. The difference being with people who are experiencing substance use and other addictive disorders, the chemicals actually interact with their brain in a way that makes it really resistant to change. Now, it doesn't mean that it's impossible, but there's actual a chemical restructuring that happens. So, are we familiar with the reward pathway?
Do you mind giving a little summary of it?
Sure. So
Yeah.
all of us have within our brain a structure called the reward pathway. I'm not going to try to name all the terms, but our memory is involved, neurotransmitters are involved. So the reward pathway essentially gives us chemical rewards when we engage in things that are life sustaining. So drinking water, eating food, exercising, procreating, all of those things, we get a little chemical boost that says, that felt good. You need to do that again because it is pertinent to our survival. Otherwise, we probably wouldn't do it because human beings in general are kind of hedonistic, where we seek out the things that feel pleasurable and try to avoid the things that feel painful. So our reward pathway is involved in all of that. The things that feel really pleasurable, it kind of makes the big imprint and says, do that again. Same thing with things that feel painful, makes a big imprint, says, don't do that again. So, drugs and alcohol interact with the brain's reward pathway in a way that's similar to how the things that naturally provide us those rewards do. So, we're all adults here. If you think about the act of procreating or eating a nice meal, how pleasurable that feels, multiply it by 2 to 10 times more intense. That's typically what people experience when they're engaging in substance use. So that makes a big old imprint on the brain and says, ooh, that was fun. You need to do that again. Depending on the setting and like other factors, mindset plays a role. The actual reinforcement, like a lot of social learning happens that may reinforce or re-encourage people to engage in it. I've seen some theories that talk about sometimes people being born with like neurochemical deficits or how trauma can cause epigenetic changes that make people more vulnerable. Like there's a whole lot of things that play into the risk. I'm nerding out, getting super sidetracked, but there's a whole lot of things that play into the risk. But over time, because the brain and the body likes homeostasis, it's going to adjust how much neurotransmitters it's producing to maintain a balance. So let's use dopamine as an example. There's a lot of research that talks about how dopamine is implicated in the reward pathway. So we'll use dopamine and alcohol. Don't check my science on it. But let's say every time a person drinks, they get an increase in dopamine that pushes them above the threshold of what naturally occurs. Because we know that excess dopamine in the brain can be risky for psychosis, the body says, uh-oh, that's too much. Over time, it's going to progressively produce less dopamine. So we know that dopamine is important for our functioning. What happens when people experience withdrawal symptoms? If they abruptly stop whatever the substance is, usually withdrawal symptoms tend to be more pronounced with like alcohol, benzodiazepines, opioids. When people abruptly stop and change the amount of the drug that's in their system, if they've been using heavily over a long period of time, that creates an imbalance because the body has stopped producing as much of that the neurotransmitter that naturally occurs. So now there's a big gap that needs to be filled. And depending on what the substance is, it can create withdrawal symptoms that make people feel very, very ill. Think about how the media portrays opiate withdrawal. People are usually like very sick with GI symptoms and muscle aches and headaches and all of those things that make people very physically uncomfortable. But there's also an emotional or psychological discomfort that can come with withdrawal symptoms. All of those things kind of work together to create the perfect storm for somebody to get stuck in a loop. So it may start off as somebody engaging in substance use because of the social benefits or just because it feels good, but depending on what the substance is and the other factors that are at play, it can turn into a problem. And just with the way our brains work, we're all kind of wired for that to be a possibility. A lot of the time, what makes the difference is environment, access to healthy coping tools, things that reduce risk factors or increase risk factors. Like there were some studies that was conducted with sets of Vietnam era twins, and they found with pairs of identical twins who were separated and raised in different households, there was a trend where one would develop substance use or mental health concerns and the other wouldn't. So if you think about like twins having identical DNA, what's the difference between those pairs? It's the environment, right? So all of this stuff plays a role. Obviously, I like talking about this stuff. Any questions on anything I've said so far?
No questions yet.
Hopefully nobody's like, oh my goodness, what have you brought this lady for?
No, this is so interesting.
Interesting. So some definitions that I think are important to know, and the stuff that we'll cover in the slide deck, and I'll make sure you all get a copy of the slide deck because I want to be respectful of your time. Um, but definitions that I think are important to know, there's a difference between substance use, substance misuse, and a substance use disorder. Substance use is literally just the use of any psychoactive substance. Show of hands, how many people had coffee today? You all engaged in substance use. Because technically, caffeine is considered a stimulant substance. Substance misuse differs from substance use because it either causes some type of harm or is associated with a consequence, or it goes against the medical or legal guidelines for the use of a substance. So, taking a friend's prescription, even if you take the recommended dose, because it's not your prescription, considered substance misuse. Getting a DUI, you may have had 2 drinks, but if you get pulled over and your breathalyzer says you're above the legal limit, now that's substance misuse. Does that make sense? Substance misuse doesn't automatically become a substance use disorder. It's more in the realm of a substance use disorder when all of those neurobiological changes that I talked about start to happen that make actually changing the addictive behavior like really difficult because of withdrawal symptoms or physiological or psychological dependence. But it's the person engaging in established kind of pattern use in a way that causes clinically significant impairments and is really resistant to change. So I mentioned we would talk about co-occurring disorders, and all that means is 2 disorders occurring at the same time. What becomes important for us as counselors is looking at co-occurring mental health and substance use disorders because they are incredibly prevalent. Upwards of 50% of individuals who experience a mental health disorder also experience comorbid substance misuse or a substance use disorder, and vice versa. When people present to substance use treatment, upwards of 50% also experience a mental health concern. So the likelihood of you all encountering a client with substance use concerns, either firsthand substance use concerns or having been impacted by a family member or a friend or a partner substance use, just by virtue of that statistic is pretty high. So it's important, like, even if you don't go into specializing in addictions, which I think you should, but even if you don't, because there's such a high likelihood that you're going to encounter somebody who is either coping with or coping with the effects of someone else's substance use concerns, it's helpful to have an idea of like what you can do as a clinician to help. So I'm going to skip around a bit because I feel like I've been talking for a while. Things that are important to know. Somebody remind me, what percentage did I say? What percentage of individuals with a mental health concern are also coping with substance use concerns? Don't all shout out at once.
50?
50? Final answer?
Yeah.
Upwards of 50%. I've seen some papers say as high as 75%. So if anybody is interested in some epidemiological research, I think the last time it was published was 2024, but the Substance Use and Mental Health Services Administration, since like the 1970s all the way up to 2024, had published an annual survey that looked at trends in behavioral health. So it looked at mental health prevalence, substance use prevalence. They have some stats on co-occurring disorders that I think are interesting. I could not find in enough time for today, but if you want to look them up, it's fascinating to look at because it'll look at like what substances people are most often using, what substances are most prevalent for people like coping with depression or anxiety. And that's important because if we think about the mental health concerns that are most commonly diagnosed within the US, depression, anxiety, and that's what NIDA, the National Institute for Drug Abuse, has found has high rates of comorbid substance use. So anxiety and trauma disorders, mood and personality disorders, and serious mental illnesses like schizophrenia and bipolar disorders tend to have higher rates of comorbid substance use. And the reason for that is varied. So there are a lot of different models that try to explain like what makes co-occurring disorders so prevalent. A common factors model pretty much says that there's so much shared risk between substance use and mental health concerns, things like trauma, ACEs, that it's just bound for them to intersect. The secondary model suggests that one condition precipitates the other. So if we're looking at it from a psychological perspective, a psychological model says, well, the substance use concern develops from the individual trying to self-medicate or cope with the emotional or psychological distress that they're experiencing. So once the mental health concerns resolve, so will the substance use. The reverse also applies for the secondary models. And there are mental health conditions that can develop as a byproduct of substance use, like substance-induced psychosis. But it more or less says that the mental health or psychiatric symptoms are occurring because of the substance use. But the bidirectional model, which is essentially the gold standard, says it really doesn't matter which happened first. We need to address all of it at the same time, simultaneously, for people to have the best results. And that's where integrated treatment comes in. And it's important because the presence of co-occurring disorders can cause a more profound impact for people across kind of dimensions of wellness. So not just limited to mental health, but people experience reduced quality of life and functional impairment. Like people with co-occurring disorders are at higher risk for developing heart disease. They're at a higher risk for accidental death. They're more likely to encounter difficulty with housing or maintaining sustained employment when they have symptoms that aren't well managed, or having a difficult time maintaining like health appointments to manage chronic conditions like high blood pressure, diabetes. So when we think about some of the challenges that individuals are coping with, it becomes really kind of important for us as counselors to be able to advocate for integrated care or be a provider for integrated care. So what that would look like for you all, if you are not necessarily trying to specialize in treating substance use disorders, the basics you would need to kind of participate in integrated care. Has anybody done expert training? Screening, brief intervention, and referral to treatment training, expert? Ooh. So I will share the link um, in the email that I sent the case study in. But Governor State actually has a free expert training for health professionals that will take you through the basics of screening, brief intervention, and referral for treatment for substance use disorders. Because that, at a minimum, that's really the skill set that you would need to be able to support people who are coping with substance use disorders if you're not specializing in integrated care. So with that, having some familiarity with the different substance use and mental health screening tools, I'm going to assume that you all have familiarity with some of the mental health screening tools already, so we won't spend a bunch of time there today. Also recognizing some of the common signs and symptoms because there tends to be a lot of overlap between substance use and mental health symptoms. We talked about the bidirectional impact of comorbid conditions. The presence of one condition tends to worsen the symptoms or the treatment, like the prognosis for the other, and that's why they say an integrated approach is typically better. Historically, the field has kind of treated it in either a parallel or a sequential manner, with the parallel, like their individual may receive care for substance use and mental health concerns at the same time, but through different providers. And that's better than nothing, but because our fields tend to be siloed, communication does not always happen in a way that's effective or conducive for the individual. So that kind of complicates things if there's different schools of thought around addiction or different schools of thought around comorbid conditions, different providers taking different perspectives. That can be challenging to coordinate care. It may also reduce the likelihood that care is actually coordinated. So parallel is better than nothing, but it's not the ideal. Likewise with sequential. So sequential will treat one disorder and then once the symptoms of that resolve, focus on the other. Like there are some instances when that can be helpful, like if a person is actively experiencing psychosis or suicidal or homicidal ideations, of course we want to stabilize the mental health symptoms first so they can actually benefit from the more integrated therapeutic work, although they have some stuff that's being modified for people who are actively experiencing psychosis. So there are some instances where it may be helpful to treat one condition and focus on the other, but more often than not, because of that bidirectional impact, people tend to have better results when both concerns are being addressed, ideally within the same agency, if not by the same provider. Other things that are helpful for you to know as clinicians or counselors in training, some of the treatment approaches that have been shown to be efficacious when working with clients who have substance use disorders. So when we think about screening, it's not very different than the type of screening that you would do in a mental health setting. You want to talk with, and this applies for all of your clients, because what percentage of people are presenting with comorbid substance use concerns?
50.
Thank you. Because upwards of 50% of clients will present with comorbid substance use and mental health concerns, we want to cast a wide net when we're screening. So asking about substance use history, of course, mental health history. Client safety screening looks a little different because, of course, we want to ask the standard questions about, like, are you safe at home? Making sure that they're protected from victimization if they have any conditions that make it difficult for them to manage themselves. But also asking questions around use and withdrawal potential. And there are formal screening tools that you'll be able to use to do that. But it's important because certain substances carry a risk of fatality depending on how severe the withdrawal symptoms are. So alcohol, benzodiazepines, and barbiturates. The three of those have the ability to, their withdrawal syndromes can be fatal if they're really severe. So it's really important to kind of screen people. Like if we're asking about substance use and they confirm that they have been engaging in use, asking about like, when was the last time? What is the typical amount? Just from a safety perspective. Opioids, people may feel like they're dying, but it's typically not fatal unless there's other health things happening with them. But screening for functioning and impairment. Other things, of course, screening for risk of self-harm or suicide, risk of harm to others, substance-related risky behaviors. So let's say you're working with an individual and you're conducting an assessment and they screen positively for alcohol use and admit that they had a couple of drinks before they came into session. There are some implications to that. If they are actively exhibiting signs of intoxication while in session, legally, we can't let them drive home because that puts them at risk. It puts the people on the road at risk. It puts the agency at risk. So we have to think kind of broadly about risk of harm to others when we're working with people with comorbid conditions. We talked about the risk for acute intoxication or withdrawal potential. So some of those screening tools, and these are all free and available to the public. There's actually a book that I'd recommend if you're more interested in learning more about the topic. It's SAMHSA's Tip 42. Tip 42 that looks at treating co-occurring disorders, and all of these screening forms are actually available in the back of that book. That's a PDF that you can download for free. But the simple screening instrument, I see most agencies, well, let me not overgeneralize, a lot of agencies that use the DAST and the audit, and they're very simple and to the point, like the audit C, audit concise, is 3 questions. The DAST is 10 questions. They have a lot of these forms in different languages, and the reading level is fairly low, so people with different reading abilities can self-report using these forms pretty easily. There's also mental health screenings that SAMHSA recommends specifically for comorbid conditions. These are also available in that Tip 42 book. The WHO disability assessment, that I think you have to get directly from the WHO, but things to familiarize yourself with. Questions? So separate from a formal screening tool, because we may not always, like when you're conducting a session or when you're conducting a screening or assessment, it may not always be like covert or overt. Sometimes it can be helpful to just have a familiarity with how symptoms might present. So when we're thinking about substance use disorders, in order for somebody to be diagnosed with a substance use disorder with the DSM criteria, there's 11 different symptoms that we would look at. And for a substance use disorder diagnosis, at least 2 of those symptoms need to be present. So 2 to 3 symptoms is a mild diagnosis. 4 to 5 symptoms is a moderate diagnosis. 6 or more symptoms is severe. So the code is going to vary between substance, but that modifier is going to be the same. I think the F10s. But when we're looking at substance use disorder, it's typically grouped into 4 categories. People may experience impaired control, some social impairment, engaging in risky use, or the pharmacological and neurobiological criteria. So we talked about a little bit about the pharmacological criteria, like the development of a tolerance. Do we know what tolerance means?
Who wants to give the definition of tolerance?
Oh, that's right, because you all have done psychopharm, right?
Mhm.
Okay, so I know you know.
Like when you don't like something, but you still let it like, oh, when you don't like something, but you do it in a way, or you accept it in a way.
mean, technically, yes.
Okay.
Yes, that is the definition of tolerance. But when we're thinking about psychoactive substances, which are substances in the body, tolerance means that the body has gotten used to a certain level of the drug being in the system, and it's adjusting how much of the neurotransmitters it's making. So if one drink used to get you buzzed, after 2 weeks of continually having that one drink, it's not going to have the same effect because the body is going to adjust for the excess. So then you need 2 drinks to get the same effect that one drink used to have. That's a tolerance. People's tolerance can increase based on how often and how much they're consuming, but the development of a tolerance is considered one of the pharmacological criteria. And depending on what the substance is, if there's a tolerance, there's a likelihood that there's also going to be withdrawal symptoms, and that's the other pharmacological criteria. So experiencing things like nausea, vomiting, headache, increased anxiety, depressed mood, fatigue, like muscle aches, those are some of the symptoms people might experience with withdrawal. And if those 2 things are present, that's the pharmacological criteria. So the DSM is interesting in how it treats substance use disorders because it's the way diagnosing is set up. It can be any combination of symptoms to determine what's going to be mild, moderate, or severe. But if we think about the nature of the symptoms, some seem a little more severe than others. That's a soapbox I'll say for another day. But having familiarity with the criteria is going to be important because you are in the position as soon to be licensed professionals to diagnose. So impaired control can look like things, the individual using in larger amounts than they may intend to, or for longer periods they may intend to. So if they set the goal that they're only going to have one drink on Monday and they end up drinking 5, impaired control. Or if they express like a persistent desire to cut down and have difficulty or multiple unsuccessful attempts, impaired control. Things like experiencing cravings or spending more time or money, either recovering from the substance use or trying to obtain it, those things fit the criteria for impaired control. Social impairment is kind of what it sounds like. Withdrawing from social settings or like family events if it impedes with their ability to engage in substance use, continuing to use despite it causing different relational issues, having problems like fulfilling duties at work or school. Those are social impairment. And then risky use, again, kind of what it sounds like. If you're using in situations that are either physically hazardous or come with clear consequences. So like a really good example, a DUI. Having alcohol in your system above the legal limit and then operating a motor vehicle, that's risky use. So until I think the earlier part of this year, the CDC defined moderate alcohol use as 1 drink per sitting for women and 2 drinks per sitting for men. That guideline has changed a little bit. I'll reserve comment on what I think of it, but it's something to kind of be mindful of when we're thinking what is considered risky use, what is considered impaired control. Questions on any of the symptoms?
So with the 11 criteria of diagnosing a substance use disorder, do each of those 11 criteria stem from these 4 like main areas, like having impaired control, and there's like specific symptoms? Okay.
So impaired control has 4. Social impairment has 3. The physio or pharmacological, neurobiological has 2, and then the other 2 are risky use. But for diagnosis, because it's a little wonky, any combination. 2 to 3 would be mild, 4 to 5 moderate, 6 or more severe. Other questions? Man, time is flying. Okay. One more thing I want to say about symptoms, and then we'll talk about some evidence-based approaches. And then if we have time, I want to get to that case study. So, post-acute withdrawal syndrome. Very important to know when we're talking about comorbid substance use and mental health disorders. So people experience acute withdrawal symptoms like when they are actively detoxifying their bodies from the substance. People can also experience post-acute withdrawal symptoms or post-acute withdrawal syndrome months and sometimes years after they've established sobriety from a substance. And that's important to note because a lot of the time they'll manifest in mood symptoms. So, like people may experience increased anxiety or depressive episodes that seem like they come out of nowhere, or like increased irritability or apathy, difficulty sleeping. Um, and that's, I think, important to note because for a couple of different reasons. If we're working with somebody who's receiving psychiatric medication, um, being able to communicate with their provider when they're experiencing increased symptoms can be helpful. Also, helping the client to identify what's actually happening with them, because these symptoms can be surprising for somebody who's been in recovery and gone through the process of the initial phase of withdrawal and having these things kind of resurface out of nowhere. I've seen send people into a bit of a panic because it doesn't seem connected to anything. So being able to provide psychoeducation on pause can be helpful too. Okay, so I mentioned a lot of what you all are already learning to do and already practicing is transferable when we're working with clients who have comorbid substance use concerns. Everybody's heard of CBT, yes? DBT, motivational interviewing, medication management, stages of change. If you know those things, you know how to work with people who have substance use disorders because those are the evidence-based practices that are implemented with a decent amount of success. Treatment prognosis is different for different people with different circumstances, but um, cognitive behavioral therapies have shown a lot of efficacy, motivational interviewing, especially, taking more of a stage-wise approach to treatment, essentially meeting people where they are in their current level of motivation and targeting our interventions or our approach based on their readiness to change. If we think about it, adults don't like being told what to do. Teens don't like being told. People in general don't like being told what to do. And because of how people with substance use concerns are often stigmatized, I think the healthcare field does a lot of telling what to do and finger wagging and not necessarily supporting people's autonomy. And I would not be surprised if that had a lot to do with some of what's labeled as resistance people coping with substance use disorders kind of present to treatment. But something I'll encourage you all to consider, is it resistance or is it ambivalence? And if it's ambivalence, that's kind of a good thing. We want people to be ambivalent because it means that they're actually considering, they're not decided, but they're considering or weighing, is change worth it or not? And we can work with ambivalence if we are able to recognize it as that and not just resistance. That makes sense? Okay. So separate from the theoretical approaches, recognizing that change in itself is rarely ever a linear path is something that is incredibly important, not just with substance use, but with our clients in general. One of the earlier questions I had about us trying to change things. If you think about people who have had their brains essentially hijacked and kind of rewired, we kind of have to have a little more grace, because that change is not going to be a linear path. A good book to read, if you are interested, is an older book, but it goes through like the stages of change. It's Changing for Good by Prochaska, DiClemente, and Norcross. And those are the developers of the trans theoretical model. So they did a lot of work around looking at people who were quitting smoking and people who were like changing diet and other health habits, and kind of built the theory based on that. But they said oftentimes people will have to cycle through that little spiral 5, 6, 7, 8 times before they finally land on being able to successfully change the behavior that they're aiming for. So we expect things like a reoccurrence of symptoms or a relapse to be the norm more so than like the exception. So people establishing sobriety and then kind of going back and forth, sometimes that's par for the course. It's important that we're able to recognize things like the abstinence violation effect. Thinking about our own selves when we attempted to change something, what happens when you have a misstep? If we're not careful, we kind of get in the mindset of, oh, shoot, I've ruined all my progress. I might as well keep going and I'll try again later. That's the abstinence violation effect, and people with substance use concerns can experience that too. But with us as clinicians, knowing that that's a possibility and knowing that change is not a linear path, we can provide psychoeducation in a way that lets people know, like, we're not going to encourage you to go out there and use. But if you do, that's kind of par for the course. Come back. Let's figure out what we need to adjust in the plan. Make sense? Okay. I've been talking for a long time. Other things that I think would be helpful, and this is purely anecdotal: empathy, empathy, empathy. You don't necessarily have to know exactly what it's like to be in that person's shoes, but you can connect to your own experiences with change, right? We've all tried to change something. We've all experienced disappointment to varying degrees, some levels of failure. So you can connect to those emotional experiences, and I think do a lot to build rapport with people. Being non-judgmental is incredibly important. Non-judgmental does not mean you have to agree or approve of the behavior. Just means acknowledging it, not labeling it as a good or a bad thing, just something that is. Recognizing that language and culture matter. I'll save that for another day, but being mindful of how we talk about people with substance use concerns. Notice I say people with substance use concerns, not addicts. From this day forward, consider addict a swear word. If somebody in recovery wants to refer to themselves in that way, that is totally their prerogative. But as providers, we have to use person first language, because the problem is the problem. The people are the people. They're not the same thing. And kind of making that switch in our brain, I think, does something. It unlocks something with how we're viewing people. When you hear the word addict, what comes to mind? Does it sound like a upright citizen who is contributing to society? Or somebody with potential, somebody with a family, somebody with feelings? Not so much. But they are. They're people. People, people, people. And when in doubt, seek supervision. Okay. How much time do I have left? Do I have any time left?
Yeah, we have time.
Perfect. Questions on anything I have talked about?
I had a question about resistance.
Sure.
How di or how difficult is it to help someone when, as you mentioned before, your brain has been altered by the substance? is there some expectation that the person is only going to um, be able to change a certain amount and that you expect them to get to that level and not progress any farther?
Uh, no, no. So here's what I've learned. One, you have to take everything on a case by case basis because you have some people that will hit the ground running and some people that may take months to decide that there is actually a problem. So each person is going to be different. What has helped me is to not have expectations at all when it comes to people and their recovery trajectory because I know there's so many variables. And when I remove the expectations of like you're supposed to progress in this way or you're supposed to improve in this way, I think that inherently relieves some of the pressure that people come into the experience with. Just thinking about those stages of change, people can stay in contemplation for their entire lives, and with resistance or ambivalence, people tend to be ambivalent when they have not gotten enough information to make a decision one way or the other. So if we're gentle in our approach and just mindful of the expectations that we're coming into the session with, we can approach the ambivalence by providing information or helping them to reflect or helping them build discrepancy so they can get closer to making a decision. Is it going to happen in the timeline that we probably wanted to? More often than not, no. But it doesn't mean that it's not possible. You know, um, I have not seen. Hmm, I don't know that I've worked with anybody who it felt like they plateaued in their ability to recover. Now, sometimes depending on how severe the mental illness symptoms are, that can affect, um, for some people, some places, some of the time, that can affect like how we have to conceptualize it. So not looking at sobriety as the goal, but looking at how is the rest of your life improving? Like, how are you recovering? Like, the concept of recovery really means returning to a higher level of functioning. So, kind of
Hmm.
redefining what we're thinking about as successful outcomes. I don't know if that answers the question.
Yes, thank you so much. It did.
For sure.
Thank you.
Another question.
Isabel had her hand raised, and then there was a question in the chat as
Go for it.
Yeah, so just really quick, I apologize also if you've already said this, but I was just curious, like in terms of substance use, because it's such a broad spectrum, there's obviously many different like areas that you could like work in. So I was just curious if you had mentioned like where specifically you work, if it's like a higher acuity type of place where it's like a detox center or if it's just like outpatient level of care. Um, if you could just maybe talk a bit more about your experience on that.
Yeah, I can. So right now I'm actually in private practice. But one of my first, I actually have done a lot of work in hospital settings. So my internship experiences were at Ingalls. It used to be the Illinois Addiction Recovery Center. I don't know if they're offering substance use services there now, but they had detox, inpatient, and outpatient substance use services. I've worked at Mercy Hospital in Chicago. It's now Insight, and they had outpatient substance use. Um, and then from there, pandemic went into group practice, and now I have my own practice. Was that the question?
Yeah, thank you.
Yeah, no problem. So you can, if you were interested in a substance use specialty, you can essentially work anywhere because of the prevalence. Not everybody is so severe that they need hospitalization. Like I have my current caseload, at least two two people who are recovering from um, pretty moderate, severe alcohol use disorder. So what I've noticed outside of treatment, like if it's really severe where they have symptoms or biomedical conditions that need to be stabilized so they can engage in lesser intensity forms of treatment, they'll usually be in more of the hospital kind of residential setting. But there's a difference between treatment and counseling. Treatment is all about symptom stabilization. So if somebody goes into a 28-day program, it's going to teach them, one is going to stabilize them, ideally, and then teach them how to be sober. Sobriety is just one piece of the puzzle. And I think this may kind of connect to your question, Dejanay. Sobriety is just one piece of the puzzle because people have entire lives and the addiction is just one piece of it, or maybe how they're coping with all the other problems, or the thing that has created a lot of different problems. Once people get sober, that kind of takes the veil off to all of these other life things that may have fallen to the wayside or that may have been part of their substance use trajectory. So, treatment doesn't always address that. That's where counseling comes in. People can receive counseling and treatment, but I don't expect that to be like the primary focus. So, what I do as a clinician now is connecting with people outside of treatment to provide more psychotherapy and start to like address some of the underlying things. So, processing trauma, working on relationships or familial issues, building coping skills for different mood disorders. All kind of with the understanding of like, okay, this is how addiction works. These are signs and symptoms I need to be mindful of. I can provide psychoeducation here and how like all of that kind of intermingles, if that makes sense. So I can give an example of one of my current clients. They started with me pretty severe in symptoms and ended up getting referred to a PHP program. We stay connected for individual therapy in addition to the PHP because that's more treatment focused. So they were very symptom sobriety, getting that down pat. Fast forward 2 years, they have been pretty successful in their recovery. And now our conversations are much less about like building motivation, figuring out what recovery is going to look like for them, like what are going to be the parameters and lifestyle changes that need to happen, to like now we're talking about managing ADHD symptoms or building anxiety coping skills or working through codependence. Like all of it's still relative to the substance use, but like the best example I can think of, um, anybody watch Walking Dead? Okay. So to me, the first few seasons of Walking Dead, it was man against zombie. The latter seasons of Walking Dead, it became man against man, and zombies are kind of the background noise. I feel like addiction recovery kind of progresses in that same way, where initially it's man versus the substance, and the substance is the primary problem. But as people continue to recover, it becomes man against man. And the substance use, like that's still kind of in the background. So we want to keep an eye on it, but it's not all that we talk about. Very long-winded way of responding to your question, Isabel. I hope I got it.
Yeah, no, I understand. Thank you.
Oh, sure. Other ways of measuring client success than sobriety. You know what? I how am I doing on time?
We're good. We've got about 5 minutes left.
Okay, I'll make it short. And then you all have a case study. Give a look at that. play around with some conceptualization. How would you want to work with that client? What type of treatment plan would you develop? What type of goals would you want to see them work towards? Homework that I will not be grading because it's not my class. Oh, what was I going to say? My internship experience. I actually had a client that overdosed and died. Terrible, 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 terrible. And it taught me that, oh, shoot, sometimes people don't fully recover. And I think once that clicked for me, I was able to accept that with this work, there are going to be people who get it and are able to move forward and live a happy and healthy life. And there are going to be people who get some of it, and there are going to be people who maybe don't. My job isn't necessarily to fix or to save anyone. It is to really try to work with them where they're at. And if I get to see them experience recovery, fantastic. If I don't, I kind of move forward with the idea of, okay, I've planted the seed, or I've watered the seed, or I gave the seed some sun. Like I've done something to contribute. So the client that passed away, they had been in recovery for a few months, and the week before they had passed away, they were in group talking about how they had gone to their first wedding sober and how they were a really bad dancer. So the reframe I was able to kind of do with that situation after I boohooed about it was, it's not the outcome that I wanted for them, but their family got to see them sober. They got to have this experience. So the last parts of their life were really good. So finding your own ways because relapse happens. Um, that was not the question now that I'm looking at it. Putting blame on self and I would not measure my success as a clinician based on whether or not a client experiences a recurrence of symptoms just because of the nature of addiction. You can give 110%. And because people's brains get changed and our society doesn't necessarily create conditions that make it easy for people to recover, it's kind of something that happens. But I've accepted that as a part of the work, and I approach it more like, okay, that didn't work out. What in the plan do we need to change for you to be able to take the lesson and apply it to next time? Does that answer the question?
Yes.
Good.
And if I can add into, if you don't mind, Dr. Love Jordan, I mean, when we look at our field, we can have our perceptions of client success and we might have our own goals that we want to see them achieve, but ultimately it's a collaborative process. So sometimes we have to bring ourselves down and adjust our expectations to what the client views as success and progressing.
Absolutely. Harm reduction. Sometimes success looks like harm reduction. If somebody is drinking 5 days a week and they narrow it down to two, we can consider that kind of successful. If people are experiencing a reduction in symptoms or they're able to maintain a job or, you know, thinking about the tenets of what it actually means to recover from something. Well, I feel like I've talked enough.
Thank you so much for coming to our class.
Thank you